Hello, my name is Sebag Olmeseken and I will be presenting the hypertension, diabetes, and dyslipidemia case. PJ is our pleasant 61-year-old African American female who's here for her annual checkup. Overall, she has been doing well with the complaint of a few recent urinary tract infections and a yeast infection that she has found a terrible nuisance. On her last visit, her metformin was titrated to 2 grams daily due to her progressive rise in A1C. She has not started a low carbohydrate diet but has worked to cut her salt and cholesterol intake since her last visit in July. Overall, she's feeling well and is encouraged about the progress that she has made in losing weight, exercising, and improving her diet. PJ would like to continue to lose weight if possible. She does not currently have any symptoms of dysuria. She has reported avid compliance with her medications, stating, "I never miss a single dose," and has worked to lower her overall cholesterol intake, and she is tolerating all her medications well. Her past medical history include obesity, dyslipidemia, hypertension, diabetes, osteoarthritis, smoking history, and postmenopausal and metabolic syndrome, a UTI that she had on April 3rd, 2020 and January 6, 2021, vulvovaginal candidiasis on August 5th of 2020. Her social history includes a former smoker. She's married for 33 years. She does not drink any alcohol. She has low salt and cholesterol diet. Exercises 3 times a week, which is mainly walking. Her family history includes her mother, who died of heart attack at age 62. Her vitals include her blood pressure of 144/83 and 146/87. Her BMI of 28.7, her A1C is 7.6, her waist is 36 inches, and her height is 5'4". Her medications currently include atorvastatin 80 milligrams daily that is used for her dyslipidemia, aspirin 81 milligrams a day for cardiovascular disease prophylaxis, her metformin 1000 milligrams twice a day for her diabetes, acetaminophen 650 milligrams a day as needed for osteoarthritis, and she is allergic to penicillin, which she gets an anaphylaxis reaction. To prioritize her problem list, among her high priority are hypertension, diabetes, and dyslipidemia. Moderate is osteoarthritis and obesity, and low is the UTI and vulvovaginal candidiasis. An assessment of the disease and drug therapy for dyslipidemia. The assessment of the disease is patient's efforts in increased exercise activity and cutting salt and cholesterol, along with her atorvastatin dose, have been successful in lowering her LDL and maintaining her HDL within target range. However, her total cholesterol and triglyceride levels have not been lowered. As described by National Cholesterol Education Program, Expert Panel on Detection, Evaluation, and Treatment of High Cholesterol in Adults, the recommended cut point for high triglycerides is 200 to 499 milligrams per deciliter, and this patient's triglyceride levels are at 210 milligrams per deciliter. This, along with the elevated cholesterol levels of 227 milligrams per deciliter, categorizes this patient as having mixed hypercholesterolemia. Contributing factors to her condition include metabolic syndrome, diabetes, and obesity. Goal of therapy for this patient should be to lower her ASCVD risk, which is currently at 20.3%, and lower her CV event risk and lower her total cholesterol levels to below 200 milligrams per deciliter, also to prevent development of pancreatitis. An assessment of the drug therapy for dyslipidemia. The patient is currently on monotherapy with atorvastatin 80 milligrams daily, and a treatment with high-intensity statins such as atorvastatin 80 milligrams should reduce the LDL levels by 50%. While this treatment has been effective in lowering her LDL to within recommended range, it has not lowered it by 50% since the initiation of the therapy. This therapy has also not been able to effectively lower her triglycerides to the total cholesterol to within recommended range, which per NCEP ATP3 recommendation, normal triglyceride levels should be below 150 milligrams per deciliter and total cholesterol below 200 milligrams per deciliter. And this is per Endocrine Society recommendations for patients with moderate to severe hypertriglyceridemia. Triglyceride levels of between 200 to 1,999 milligrams per deciliter. Treatment considerations should include one of three treatment classes: fibrates, niacin, omega-3 fatty acids, alone or in combination with a statin therapy. This is a weak recommendation and low quality of evidence per the Endocrine Society. As for the recommendations, recommendation number 1 is the patient should be encouraged to continue her lifestyle modifications and improve upon them to further lower her weight. The lifestyle recommendations by ACC-AHA, National Institute of Care Excellence, and European Society of Cardiology, European Atherosclerosis Society include dietary changes, including reduced intake of saturated fats and refined carbohydrates and increased physical activity. According to AHA, intensive lifestyle changes can reduce triglyceride levels to 50% or more with combination of 5 to 10% weight loss, reducing added sugars and fructose and increasing unsaturated fat intake, increasing marine-based omega-3 fatty acid intake, elimination of trans fats, and increasing aerobic exercise. Patient has already lowered her intake of salt and cholesterol and should be encouraged to reduce her carbohydrate intake and resist the urge to occasional splurging, and recommend exercises that are not stressful on her knees, for example swimming and resistant training. For monitoring for efficacy, we should continue improvement in body weight, and for safety we should monitor stress effects on the knees. The second recommendation would be to continue the treatment with atorvastatin 80 mg once daily as prescribed. And for monitoring of that efficacy, should continue monitoring the lipid panels for indications of continued improvement of the LDL levels within normal limits. And for safety, should monitor for signs of myopathy if symptoms are suggestive. For patient counseling, we should counsel patient on signs of myopathy, which is muscle pain, arthralgia, which is severe joint pain, and urinary tract infections. Counsel patient about directions to taking this medication. There's no food restrictions, not to miss a dose, and do not split the pills. Also warn patient about the interaction between grapefruit and atorvastatin. Recommendation number 3 is, in addition to atorvastatin therapy, to initiate therapy with fenofibrate at 48 milligrams PO daily and titrate the dose up to 4 to 8 weeks intervals up to 145 milligram target dose. Dose adjustments should be made according to patient tolerability and response to therapy. Based on the results from the ACCORD trial and its extension of accordion trials, statin-treated patients with elevated triglycerides and low HDL had reduced risk of CVD events when fenofibrate was added to the statin therapy. For monitoring of efficacy, we should monitor the lipid panels every 4 to 8 weeks, the HDL cholesterol levels, and for safety, we should monitor liver function tests, baseline and throughout the duration of the therapy, and a complete blood count. For patient counseling points, patients should report to the doctor if they have any of the following side effects: very bad joint pain or swelling, feeling very tired or weak, chest pain or pressure, fever or chills, shortness of breath, and coughing up bloods. And some side effects include headache, back pain, and belly pain. As for the diabetes assessment of the disease, ADA defines type 2 diabetes in adults as varying degrees of insulin resistance and insulin deficiency. The glycemic goals set by ADA for non-pregnant adults with type 2 diabetes is an hemoglobin A1C of less than 7%, preprandial glucose levels of 80 to 130, and peak postprandial glucose of under 180 milligrams per deciliter. This patient's elevated A1C of 7.6% and glucose of 157 milligrams per deciliter classify her as a type 2 diabetic. And the contributing factors to her diabetes type 2 are metabolic syndrome, being overweight, her race, age, diet, and family history of her father. The goal of therapy is to lower her risk of CV event and progression of type 2 diabetes by lowering her A1C to below 7% and fasting blood glucose to 80 to 130 milligrams per deciliter, and more aggressive A1C targets of less than 6% are not recommended and may lead to increased mortality in patients with type 2 diabetes, and that is based on results from the Accord study. I agree with providing the patient with home testing devices like glucometer and test strips, and a referral to an ophthalmologist. Assessment of the drug therapy for diabetes. This patient is previously placed on lifestyle modification and metformin therapy in order to slow or prevent progression to type 2 diabetes. Evidenced by her lab results and elevated blood glucose on A1C, the current therapy is not sufficient and her therapy should be reevaluated and will benefit from the addition of a second agent. Patient's efforts in cutting salt and cholesterol from her diet and increased activity should be congratulated, but she should be encouraged to take further steps to optimize her treatment to reach her treatment goals of A1C of under 7% and fasting blood glucose of between 80 to 130 milligrams per deciliter. As for recommendations, the number one recommendation would be to provide diabetes self-management training or diabetes self-management education, as defined by the AADE, American Association of Diabetes Educators, is a collaborative process through which people with or at risk for diabetes can gain the knowledge and skills needed to modify behavior and successfully self-manage the disease and its related conditions. It is an interactive, ongoing process involving the person with diabetes or their caregiver or family and a diabetes educator. The aim is to improve quality of life and health status, and diabetes education focuses on the following 7 areas: healthy eating, being active, monitoring, taking medication, problem solving, healthy coping, and reducing risk. The second recommendation for diabetes would be to continue with the dietary restrictions in combination with physical activity, glucose monitoring, and self-management as recommended in first recommendation, along with medical nutrition therapy by a registered dietitian nutritionist. This is an ADA grade A recommendation. They should include nutrition assessment, monitoring, and evaluation, and ongoing follow-up to support lifestyle changes, evaluation of outcomes, and modification of interventions as needed. We should encourage to continue the physical activity at least 3 days of the week. For monitoring parameters for the first 2 recommendations, for efficacy, we should monitor for lowered total cholesterol and A1C and a weight loss of between 5 and 7%. And for safety, we should monitor for patients' physical well-being, which includes her knee pain and overall quality of life. Recommendation number 3 would be to continue the metformin at 1,000 milligrams BID dosing. Metformin is the preferred drug at diagnosis unless it is contraindicated. This is an ADA grade 1 recommendation. And if hypoglycemic goals are not achieved after 3 months, then a second agent should be added to the drug regimen. For monitoring for metformin, we should monitor for efficacy by fasting blood glucose levels and A1C levels. And for safety, we should monitor urine for glucose and ketones, renal function annually, and the vitamin B12 concentrations. For patient counseling, patients should be counseled to take the medication with food and a full glass of water, and we should warn patient of the GI side effects such as nausea, vomiting, and cramping. Recommendation number 4 would be to initiate sitagliptin 100 milligrams daily. This medication, being a DPP-4 inhibitor, is weight neutral and will not contribute to the patient's weight, which is an ADA grade E recommendation. It is also generally well tolerated with low side effect profile, and on average, it can contribute to a 0.5% reduction in the A1C. This is in conjunction with metformin, which can also contribute 1 to 2% in the A1C reduction, can bring the patient within target range. For monitoring of efficacy, we should monitor fasting glucose levels, A1C at least twice yearly, and for safety, we should monitor renal function and periodically, since this drug may need dose adjustments based on renal function. For patient counseling, we should counsel patient about recognizing signs of kidney problems like difficulty passing urine or blood in the urine, Also signs of pancreatitis such as severe stomach and or back pain and throwing up. We should warn patient of the possibility of low blood sugar, dizziness, headache, and weakness. Possible side effects include headache, sore throat, runny nose, and stuffy nose. Recommendation number 5 would be an alternative to the recommendation number 4. We should educate patient about the benefits of a GLP-1 agonist and weight loss. Even though these agents are injectable, they might prove beneficial for her in terms of assisting in weight loss. If agreeable, we should recommend initiation of liraglutide at an initial dose of 0.6 milligrams sub-Q QD for 1 week. Titrate the dose up by 0.6 milligrams once weekly, 0.6 milligram once daily at weekly intervals to a target maintenance dose of 3 milligrams sub-Q once daily. And if the target dose of 3 milligram QD is not tolerated, the medication should be discontinued since the doses have not shown to be lower doses have not shown to be efficacious. And liraglutide can reduce the A1C by 1%. For monitoring efficacy, we should monitor blood glucose, A1C, and body weight. For safety, renal function, signs and symptoms of pancreatitis, triglycerides, changes in behavior, and heart rate. For patient education, patients should not share pen or cartridge devices with anyone, even if the needle has been changed. Monitor blood sugar regularly, and some side effects include dizziness, rapid heartbeat, mood changes, low blood sugar, and pancreatitis. Recommendation number 6, if recommendation number 5 is not agreeable, in selected patients with type 2 diabetes and BMI of 27 kilograms or more, weight loss medications may be effective as adjuncts to diet and exercise. This is an ADA grade 1 recommendation. And a medication that may reduce weight in patients with type 2 diabetes is orlistat. Orlistat is indicated for obese patients with an initial BMI of 30 kilograms per meter square or more, or 27 kilograms per meter square or more in presence of other risk factors such as hypertension, diabetes, and dyslipidemia. Orlistat should be dosed at 120 milligrams TID with each meal containing fat. Patients should be instructed to omit dose if meal is missed or contains no fat. For efficacy, we should monitor the BMI, and for safety, we should monitor serum glucose, renal and liver function tests, monitor for fat-soluble vitamins A, D, E, and K, and counsel patient on the following: the loose stools, not being able to control stool, belly pain, gas with discharge, upset stomach, and back pain. And for hypertension, assessment of the disease, patient's current blood pressure reading of 144/83 and 146/87, and her previous readings of 147/89 and 148/92 classify her as a stage 2 hypertensive. According to ACC/AHA recent definition, hypertension is defined as systolic blood pressures of 130 or higher, or diastolic blood pressures of 90 or higher, and according to their categorization, systolic blood pressures of 140 or higher or diastolics of 90 or higher is categorized as stage 2 hypertension. Contributing factors to these patients' hypertension include obesity with a BMI of 28.7, and a target blood pressure should be less than 130/80 for patients with confirmed hypertension and known cardiovascular disease, 10-year risk, ASCVD risk of 10% or higher. According to ACC/AHA guidelines, in this patient's pooled cohort, 10-year ASCVD risk is estimated at 20.3%. Patient's weight has improved since initial assessment based on lifestyle modifications made, but still has room for improvement. Other contributing factors to her hypertension are her age, race, metabolic syndrome, and diet. Blood pressure targets of less than 140/90 are not associated with a reduced mortality or morbidity except in patients with diabetes. And in patients with diabetes, ADA and ACC/AHA guidelines recommend blood pressure target goal of less than 130/80 millimeter mercury. In assessment of the drug therapy, patients not currently on any pharmacotherapy for hypertension, the physician's plan to starting her on lisinopril is not recommended in Black patients per ACC/AHA guidelines, since this population tend to have a greater response to therapy with thiazide diuretics and calcium channel blockers. This patient has a compelling condition of diabetes along with a hypertension and will benefit from dual therapy, and her drug therapy should include a 2-drug combination. According to ADA guidelines, if hypertension is present along with diabetes, the initial therapy choice must include an ACE inhibitor, an ARB, a calcium channel blocker, or a thiazide-type diuretic. And according to JNCA recommendations, for Black patients with diabetes, evidence-supported recommendation has shown that thiazide-type diuretics or calcium channel blockers are associated with lower rates of stroke, heart failure, and CVD compared to ACE inhibitors in subgroup analysis of ALL-HAT trial, which included both patients with and without diabetes. Among calcium channel blockers, dihydropyridine calcium channel blockers are preferred, and the goal of therapy is to lower the blood pressure to below 130/80 if tolerated without undue burden. So as far as the recommendations, the first recommendation would be patient should continue on lifestyle modifications and more dietary restrictions and avoid the urge to occasionally splurge. She should reduce the carbohydrates from her diet and be encouraged to follow a DASH type diet, which includes consumption of fruits, vegetables, and low-fat dietary products with reduced saturated and total fat. Patients' low-salt diet should be encouraged. Alternative physical and aerobic exercises that exert less stress on her knees, such as swimming, should be offered. Patients' weight loss goal of 7 to 10% should be maintained. We should monitor for safety for continued weight loss of 7 to 10%. That's for the efficacy, and for safety, we should monitor patients' knee pain and overall quality of life. Second recommendation would be to initiate chlorthalidone therapy with the initial dose of 12.5 milligrams daily. According to the results of the ALL-HAT trial, chlorthalidone produced fewer cardiovascular complications than amlodipine and lisinopril, and this effect was more prominent in Black patient population. Chlorthalidone should be initiated at a dose of 12.5 milligrams daily and increased to 25 milligrams daily as tolerated by the patient. We should monitor for efficacy the blood pressure lowering at a target range of less than 130/80 and edema, and for safety, the serum and urine electrolyte balance, especially the potassium levels, renal function for proteinuria, serum creatinine, and albuminuria. For patient counseling, patients should be aware of chance of dizziness initially when starting this medication, should rise up slowly if sitting or laying down, monitor the blood glucose closely, check blood pressure often. This medicine may cause hard stools. To avoid using salt substitute containing potassium, and consult a doctor or pharmacist when taking over-the-counter medications. Recommendation number 3 would be to initiate amlodipine at 5 mg once daily, and the dose can be titrated up to a target dose of 10 mg once daily every 7 to 14 days. The target dose according to JNCA guidelines. For efficacy, we should monitor the heart rate and blood pressure, and for safety, we should monitor the physical findings such as monitor the supine blood pressure weekly during initial titration, which is 2 to 6 months. And we should monitor peripheral edema. For patient counseling, warn a patient about dizziness, flushing, feeling tired, upset stomach, these are some of the possible side effects of this medication. We should monitor blood pressure frequently, tell patient to rise up slowly from sitting or laying down positions, and be aware of signs of liver problems, which is dark urine, feeling tired, not hungry, upset stomach. And we should tell the doctor if they're developed any rapid heart rate. For patient follow-ups, according to ACC/AHA guidelines, for adults with stage 1 hypertension and estimated 10-year ASCVD risk of 10% or higher, repeat blood pressure evaluation in 1 month following initial management with combination of antihypertensive drug therapy and non-pharmacologic therapy, and team-based care approaches such as nurse and pharmacist-led teams have been associated with improved blood pressure control. Thank you.